So the next talk is from Dr. Sayan Das, who is a radiation oncologist from Calcutta. He'll speak on the PACE-A randomized trial of radical prostatectomy versus stereotactic radiotherapy for localized prostate cancer.
Hi, very good morning to you all. And I'd like to thank the organizers for giving me this opportunity. I'll be discussing the results of the PACE-A randomized trial. As we all know that for early and intermediate risk prostate cancer, there are several treatment options, which include surgery, radiotherapy, which includes SBRT as well. The PROTECT trial has already showed similar survivals, which kind of makes the shared decision making to be very important, where people take decisions based on the quality of life and side effect profiles. Now, historically, based on retrospective data or single center data, that radiotherapy has been associated with better urinary and sexual outcomes, but more bowel toxicity when you compare it with prostatectomy. However, there was no confirmation in a randomized setting. So this is what was the objective of the PACE-A study, which compared patient-reported health-related quality of life after SBRT versus radical surgery in men with low to intermediate risk prostate cancer. It's a phase 3 randomized control trial. They included men with low to intermediate risk prostate cancers randomized to SBRT or surgery in a 1:1 ratio. However, they did not permit any ADT. So 123 patients randomized, 60 to the surgery arm, 63 undergoing SBRT over a period of spanning almost 10 years. So you can understand how difficult the actual was. The median follow-up of around 5 years, median age around 65 years, the median PSA around 8, and around 94% had, so it was mostly intermediate risk group. 50 out of the 60 patients allotted to the surgery arm underwent surgery, and 60 out of 63 received SBRT. So what was the primary outcomes? So they included a co-primary outcome because there was some change in the protocol in view of the slow accrual. So the co-primary outcomes at 2 years was the number of urinary pad used per day plus the bowel domain score based on the EPIC 26 forms. And secondary endpoints included physician-reported toxicity, sexual functioning, and other patient-reported outcomes like IPSS and the fecal incontinence score. With regards to radiotherapy, the standard doses which we all practice is around 36.25 gray in 5 fractions. They give slightly higher dose to the CTV. Prostatectomy, majority, 84% underwent robotic surgery. Looking at the key results, urinary function at 2 years, prostatectomy 50%, so 16 out of 32 patients used 1 or more pads daily, vis-a-vis 6.5% with radiotherapy. With regards to urinary incontinence scores, significantly worse with surgery. Urinary irritative for obstructive scores were slightly worse with SBRT. However, no significant difference in the overall urinary bother when we looked at moderate or severe problems. With regards to bowel function, here surgery scored better compared to SBRT. Around 45% in the radiotherapy arm had a reduction from the baseline bowel score, more than what was considered as a minimal, clinically meaningful difference, versus 14% in the surgery arm. However, again, no significant difference when we looked at moderate or severe bowel problems, and no difference in the rectal incontinence scores. With regards to sexual function, where again radiotherapy scores better because these sexual domain scores were worse with surgery. Clinically important worsening, 75% in the surgery arm versus 48% in the radiotherapy arm. Overall sexual bother here, SBRT scores better than surgery. Erectile dysfunction, again worse with surgery. And when we look at clinician reported erectile dysfunction, again consistently worse with surgery. The limitations were again slow recruitment and the sample sizes. So the trial stopped before reaching the target accrual after discussion in the data monitoring committees. Although one must say that one should not worry about the study being under powered, because the high number of event rates kind of mitigated that problem, because when the study began, the initial sample size was thought to be 15% of pad use for the surgery arm, which ended up being 50%. The other issue was incomplete 2-year patient-reported outcome response rates. Slightly more responses available for this radiotherapy arm. However, sensitivity analysis done where they imputed the 3-year data for the missing 2-year data, and they showed that the results were consistent. Some patients did not receive their allocated treatment more in the surgery arm, which may have introduced some selection bias. To conclude, SBRT was associated with less patient-reported urinary incontinence, less patient-reported sexual dysfunction, slightly more bowel bother compared to surgery. However, overall, moderate or severe problems were kind of uncommon and same in both the arms. So what this data is important in taking treatment decision making for patients with mostly intermediate risk prostate cancers, because it helps them to choose which one based on the adverse effect, the side effect profile. So my take is, when you are going to decide treatment in this group of patients, don't think just about cancer control, because we have data that is almost the same. But look at the quality of the survival. Look in details about the nuances in the toxicity, because high pad use in the surgery arm was pretty significant quality of life issue, which kind of aligns with similar studies, the pivot and the LAPRO results. SBRT, slightly more bowel bother, but as Dr. Triranjan said in the last panel, what is a GI toxicity significant in the West may not match with our population. We need to look at longer outcomes, whether periatrial spacers can bring down this rectal toxicity much, and cost-effective analysis. My takeaway message would be, it's not about whether one treatment is better than the other, but about which treatment aligns better with an individual patient priority. Thank you.